Okay, guys, we are ready. So I'll start out. First system is Vertebral Augmentation system session. First system we'll be using is the spine jack. This is from Stryker. And the first thing I'd like to do is show you the needleology of this. And so if we could focus down here where the tips of the needle are. Eye up, camera down here. And first is we have a diamond tip. This is this one. And we can see it's multi-beveled. The other one is a single bevel. So this will access any point along a curvilinear surface. This is directional capability of a needle. So I'm a bevel tip preference, so I'm going to swap these out, and we will see what we have in terms of anatomy that's amenable for augmentation. Basically, any anatomy is amenable to augmentation. So we'll start off here. So this is a typical spine jack flat approach. So instead of the 10 o'clock, 2 o'clock position, we're going to go 9 o'clock and 3 o'clock in order to get that tip as horizontal as we can, the whole trajectory as horizontal as we can, so we can have the spine jack butt up against the end plate flat. So I'm going to start my transpedicular approach like this. I'm going to take it all the way down, and we don't transgress across the medial wall of the pedicle until second needle, until we're at the posterior wall, inside the posterior wall of the vertebral body. So I'm going to cheat a little bit. I'm going to get a start to kind of abbreviate this. And before we look lateral, I'm going to get a bilateral needle placement on the AP view. Then we'll look lateral to check and make sure we're across into the posterior wall. And I'll show you a tip or trick on how to do that. Pretty obvious tip. So again, this is 9 o'clock and 3 o'clock. Go down a little bit. And before we transgress that medial wall, we're going to take a look lateral. This nice bilateral needle placement. So John, let's take a look lateral. And we'll make sure both of these are in the posterior portion of the vertebral body. And then we will add the K-wire and proceed on from there. Okay, so they're very much overlapping as would be expected. And so we're going to take the stylet out of one of these so we can see where the needle position is on the other. So that's in the posterior wall. I'm going to drive it forward just a little bit. And we can see that. Then I'm going to swap these out and make sure the other needle is in to the posterior wall. Pull the stylet back, and the other needle is almost identically placed. And we're going to advance that forward a little bit to swap these out with the K-wires. Thank you, Grant. K-wire. And so we're going to place these on both sides. What I'd like to do is place these both out the anterior portion where the tip of the spine jack will be. And we'll get a good idea about where the final position of the spine jack will be because the reamer goes over the wires. So this wire placement is going to be adequate. And the other wire placement is right on top of it. All right, so John, let's come back AP. And I'm going to assume that this is going to be okay, and windshield wiper remove these cannulas out. Yeah, great. So by the looks of it externally, this is okay. And even if we have a little bit of need to medialize these a bit, which we don't, is perfect, we can medialize them with the reamer. So thanks. Oh, 2 of them. Very nice. Let's go back lateral. So next is insertion of the reamer, and it looks like a drill, but it's fluted. It has cutting edges on the side of the drill. It's also self-tapping and fairly aggressive. So We just have to make sure and mind the tip of the wire that we don't go through the front part of the vertebral body. It is blunt, by the way, but you do lose style points for going through the anterior portion of the vertebral body. So don't do that. And so we'll come all the way down, and the tip of the reamer is size matched. So the larger diameter of the reamer is exactly the same size as the 5.0 spine jack. And this is blue, which means it's 5.0. There are 3 sizes, 4.2, 5.0, and 5.8. And this has to do with the diameter. I'm going to put a reamer on the other side. Let's go ahead and advance on. And we'll see the other one coming in. The advantage to having the needles placed in a very homogeneous appearance is that these are targeted very well. The disadvantage is sometimes you have trouble seeing the other one through the first needle. But you can do a wig-wag. We're not going to do that this time because I want to do it for the sake of brevity, and also we can see these well enough, so we'll take the spine jacks now. Oh, template first. So typically I will skip this part, but for demonstration purposes, we need to demonstrate it appropriately. So on this, I will take the template, which is also size matched, and this is octagonal in shape, and this will go in and clear out all the bone debris, and we can see this, and this is rounded, and it has a blunt tip, and you can use it, you can tap it forward. I'm going to demonstrate that. If you want to put the spine jack toward the very front, you can even tap this forward, and it has a blunt tip, so you don't have to worry about hitting anything, damaging anything. So next we'll take the jack. The spine jack, if we could have a camera on table, this deploys coincident with the handle. So the jack, which is here, made out of one single laser cut piece of titanium alloy, will deploy the same direction as the handle, which I'm holding on to here. The butterfly handle will cause a deployment. The colored knob will detach this, and this whole apparatus will come out. So as we will see, I'll deploy this. We'll put it in position on fluoro. It's nice. I'm going to advance it just a little bit farther. It's in position, looks great. We're going to take the other jack. We'll take the reamer out along with the K-wire. Thank you, Grant. We'll replace the jack, place it forward. We can see they're overlying each other. I won't come back around to AP because I kind of know where it is on the AP based on our K-wires. And I'm going to deploy this. And so I'm going to deploy this one. Grant's going to deploy this one. So we're going to grab the handle. Let's grab the handle here. And we're going to righty-tighty on the butterfly handle while keeping it stable. 2 or 3 turns, and we're going to pause. We're going to take a shot. And so we can see the implants starting to deploy, and it's like a scissor jack. Unlike a jack that sits in the trunk of your car, this deploys not from the ground up, from one spot superior. It deploys from the center post, superior and inferior. And we can see the jack starting to come up, and this is a very powerful way to reduce fractures, to expand it. So we're going to come all the way to the very end. This has 10 turns, and it's a hard stop. Keep going until you feel a hard stop. And then we're going to unscrew the colored knob. Is that loose? Okay, and with the snap of the wrist, you just do it like this. Very nice. You're natural. And then it's time for the cement. So the cement should be coming to us very shortly. I don't know if it's been mixed. All right, so the final deployment of the jacks are this. So these will open up. These are 20 millimeters, the ski length, front to back. These will open up to 17 millimeters top to bottom. So this is one of the very nice ways to reduce and restore height in a vertebral body. Let's go around AP. So in the SACOS trial, comparing jacks to balloons, it had a statistically significant restoration, better restoration of middle vertebral body height than did the balloons. So we'll take an AP shot, very nice. That's exactly what we want. And our end plate for cement distribution will be, this will fill the tracks left by expansion of the jack first. It will tend to go anteriorly, form kind of a C shape along the, let's go back to lateral, along the deployment of the jack, and it will tend to meet in the middle. And one of the things you want to make sure and do, let's go with the cement, is make sure you get the cement that meets in the middle. So very osteoporotic patients or patients with very poor bone quality, it has to meet in the middle. Otherwise, it has a potential to the vertebral body might fall apart. So we're going to place the cement, and as we place the cement, this is Stryker's high viscosity cement. This comes out at about 800 Pascal seconds. So this stuff is very viscous, very easy to control. And it has to be injected through a bone filler. And you can see the cement coming out. I'm going to switch sides. Always put something to block the cannula on the other side, because the cement can and will go to the other side and then up the cannula. So you have to keep something, keeping it in place. You can see the cement coming as a double density on the other side. It's looking pretty good. All right. Let's come back AP, John, see how we're doing. That looks very decent right there. Okay. So, AP shot, filling both tracks, meeting in the middle. Wonderful. I think that's a wrap right there. And so again, spine jack, and whenever it's time to pull these out, one of the things I want to focus on it, if you could go back lateral, we have to make sure that the cement will not backfill. So we take the bone filler or the plunger, we'll take it, we'll put it back in, and we'll make sure that this has a tap to it, that the cement is hard enough not to come back out as we remove the cannula, the working channel. So we'll take this, and one of the things, it's a number of different ways to remove it. You can just twist and turn, and it comes right out. One of the things to troubleshoot before you get into this predicament, I've seen people get into trouble that, let's see, K-wire here, and sometimes cement, just like it's very resistant to compression, is very resistant to distraction. So cement has almost no resistance to shear force, almost none. It's very resistant. You can take a stick of chalk made of made of cement, and you can take it and you can hammer on it and you can't break it. But you can take it and just tink, it breaks right in half. Same here. I've seen people that call and send me a video of them pulling up on the patient lifting the patient almost off the table, panicking. You know, what do I do about this? It's stuck. So what you do is you find the hole in the proximal portion, and you insert the K-wire, and you turn it, and you pull it right out. And it's just that easy. Cement has virtually no resistance to shear force. So just turn it, twist, pull it out. Very easy. And that is the spine jack.
Doug, what's the average volume per vertebral level to cover the two spine jacks? What's the average volume of cement?
Volume of cement is about 6 to 7 cc's. So remember, I'm a over cementer probably. I cement a lot, and I love cement. The more cement, the better in general. Spine jack has that's my average volume. Spine jack on just across the user spectrum will have about a third less cement than balloon kyphoplasty. Part of the reason is when there's more trabecular bone. When you raise the jack, you deploy it, it doesn't deploy centrifugally like a balloon. It doesn't deploy from the center out. It just goes up and down. So you have a little bit of trabeculation that's left over. The other is the spine jack is a space-occupying lesion. I mean, you have a titanium alloy implant in there that takes up space that would otherwise be occupied by cement. So anything from about 4.5 to 8 cc's will be about the average across the board in the thoracolumbar spine. With that, I think we're going to go ahead and change over, and we'll demonstrate balloon kyphoplasty with Dr. Hatheway.
Bring it over.
Okay, come on.
Okay. Should we move this? Yeah, let's do that. Be careful. Yeah, thanks. Need that. Need that. What's that?
Your microphone.
Aha. Perfect. All righty. Okay, hi everybody again. No fish pictures this time, so you'll have to go without. Just want to show a couple different things here. Similar, there's different tips that one can use for the procedure. The one I like to use the most is a bevel tip, and there's a triangle on the end that shows you which direction it's going to go. And being an interventional pain doc that bends all the needles away from the bevel, this gives you some directionality of where the trocar is going to go. There's also a tri-tip needle trocar here, and then we have a diamond tip. One of the benefits of utilizing a diamond tip is that this tends to seat into the pedicle a little bit easier than the other two. So if you're having trouble getting it to seat into the pedicle, then that can be a good option. What we're going to demonstrate today is a special cannula, which is called the Kyphon Assist. And as you can see, this has an opening that's going to allow you to direct the balloon in one direction or another. So if you have a patient that you know that there's probably a hole in the superior end plate or inferior end plate, you can put this in and direct the balloon away from that hole. So we'll show you how to do that today. All right, so let's go to AP, please. And we'll find an unused level. What's that? Yeah, down. Okay. I guess we'll go for the one above that Doug did. So let's line up those end plates. So if you can tilt, first name is John, right? Yes. That's easy, John and John. Right. Tilt down a little bit. Yeah. To line up the end plates. And a picture again. Okay, maybe a little bit more. That's pretty good. All right, and go live for me. All right, so I'm going to start on the left side, and for time purposes, I'm just going to do a unipedicular access. So normally, I'm going to start right on the 10 o'clock position on the left side, or the 2 o'clock position on the right side, and I'm going to go up about 1 centimeter and over about 1 centimeter, and that's going to be my starting point. Let's see, scalpel. Need a scalpel, please. I think it was on that tray. Picture again, please. Great. Thanks, Doug. Okay, so we'll make a little stab, small stab wound there. And a picture, please. Okay, picture. And normally what I'll do before I actually put the trocar in is I'll take a 23 gauge, 3.5-inch spinal needle, and I'll inject local anesthetic down to the pedicle, about 10 cc's or so. Picture. All right, so that looks pretty good there. We're gonna tap that in just so it's seated a bit. Picture. Okay, let's go ahead and go lateral. And a picture there, please. Okay, so that's a nice lateral view. You can see the pedicle nicely, the superior and the inferior aspect. You can see the foramen, so I'm happy with that. We'll go back to AP. And when you're on the lateral pedicle, you should be at the posterior pedicle to be matched on the lateral view. So we're matched there. And a picture again, please. Thank you. Picture. Pretty hard bone for a cadaver. Picture up, there it is. Much softer. Picture. Picture. Okay, so now I'm at the medial pedicle. Go ahead and go lateral again for me. I'm going to check and see if I'm matched before I breach the medial pedicle. So that's a safety process. So I'm a little bit medial because I'm not quite at the posterior cortex there. So I'm going to go back to AP really quick. I'm going to turn my bevel a little bit lateral. And a picture there. Okay, so what you can see, that's with the bevel lateral. Save that to the right for me for a minute. And then if we turn the bevel medial, you can see the difference, that picture there, that just the bevel makes. So when you're a little bit medial, you can turn the bevel lateral, advance a little bit more, picture, advance a little bit more, picture, and then we'll go ahead and go lateral again, and we should be matched. Perfect. We're at the posterior cortex, so we're matched. Then I'm going to turn my bevel to aim for the anterior inferior picture. And I know I'm safe now, so I'm going to put the pedicle, the trocar in. Picture. You can also use a drill at this point. I typically like to use the trocar because I think it gives me a nicer path. Picture. Picture. Great. Then at this point, we're going to take the introducer here and put that down. Picture. And we're going to use that as kind of a K-wire-like device. And then I'm going to get the Kyphon Assist cannula. And the one thing to note with this is the little white mark will tell you which way the opening is facing. Picture. And this can be useful if you want your balloon to go more medial, or if there's, like I said, an opening in the superior end plate and you want your balloon to go down. Picture. Picture. Okay, we can take that out. Okay. All right, and we're ready for the balloon. What's that? Yeah, thank you. So this is the balloon connected to the inflator, which is digital. The typical balloons that I use are rated to 700 psi and 4 cc's. Medial. Picture. Live. Like that, stop. Okay. That's good. And let's go see the AP just to take a look at that. And a picture there. Okay. Now to be. All right. This is going to give you a PSI rating on here as well, so you know. Picture, you're not going to go over the picture. And I have the Kyphon assist facing up, so that's where the balloon is going, is up. Picture. 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 Let's go back to lateral. Usually I'll inflate the balloon on the lateral view first. There you can see the balloon going up as the Kyphon assist is directing it there. Picture. 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 And that's about a 3.5 cc balloon. I think that looks pretty good. Let's take one more view on the AP. Close. And we're using the X-Speed. So we're using, there's 3 types of cements that you can use. One is the X-Speed, which is what we're going to use, and that's going to have a fast setup time. They also make an Activos cement, and that's more of a biologic cement. So if I have a patient who is younger, in their 50s, early 60s, I'm going to use that. That tends to interdigitate more and act more like normal bone. All set? Okay. We're just waiting for the cement to set up.
John, can I ask you, while you've got the balloon in there, do you use anatomical parameters, particularly when you're using a unipedicular approach, to discern how much coverage in the vertebral body you're going to get from the balloon?
So good question. So like I said, I'm doing a unipedicular approach here just for time, but let's say we did have a patient who had a right pedicle fracture. They had stir imaging uptake in the right pedicle. So I want to avoid that pedicle, so I'm going to do a unipedicular approach. What I like to do is I like to have my balloon cross midline on the AP view, and I want to have a significant portion of that balloon crossing midline when it's blown up also. So this one would suffice because it is crossing the spinous process to the other side. And I probably could have pushed the balloon a little bit more too if this were truly a unipedicular case. Does that answer your question?
Yeah, exactly. When I do unipedicular, I make the balloon span from the medial border of the pedicle on the side of introduction to the medial border of the pedicle on the contralateral side, because that's where the strength of the end plates are greatest.
Right. But more traditionally, and in this particular case, I'd be doing a bipedicular, which would give it the best support overall. Okay. The other thing I always do before I start, if we can kind of zoom in on the tip here, is take a look at the cement as it exits the end, and it should kind of ball up like that, like you're seeing. That means that it's at an appropriate position to go ahead and inject. We'll go ahead and we'll go back to lateral, please. Well, now it's going to be difficult. Picture. Okay. And then we'll go ahead and inject. The injector here has this purple button on the back, so if you want to stop quickly, that will stop all cement from going on. So it's kind of a safety feature. And you really get feedback as you're squeezing to know, picture, when cement is actually coming out. Now I can feel that there's cement coming out, picture. And you can start to see the cement at the tip, picture. Picture. And I'm going to inject usually about 2 cc's, picture. Picture. And then I'll go to an AP view just to check, picture. And I'm going to be watching for any leak. I'm going to be watching for any vascular uptake. Picture. Good. We'll go to AP view and see how that looks. That looks good. So we'll come back to lateral. You can tell the cement is really following the cavity that was created by the balloon itself. And picture again. Picture. 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 Cement is starting to migrate a little posterior here. Picture again. Picture. So I'm watching just to make sure it's not getting onto the posterior wall. Picture. Once it gets there is usually going to be my end point. Picture. 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 And we've injected about 5 cc's there. It's getting close to that posterior wall, so I'm going to stop there. We'll go get an AP view to see what it looks like on AP. So we got a nice fill there, almost pedicle to pedicle. You can see why if you do a bipedicular case, you're going to get cement equally on both sides, so it's going to give you better stabilization of the vertebral body. But I'm happy with that, and if this were a unipedicular approach, I would be happy with that as well, because we've got plenty of cement on both sides. And that's it for balloon kyphoplasty. Oh, let me say one more thing too. In terms of taking the trocar out, I should mention that. Do we have a bone filler? Thanks. So one thing I'm always going to do before I take the trocar out is I'll use a bone filler like this. Put that bone filler in, and you'll be able to tell when the bone is hard. You'll get an acoustic tap. That's hard as a brick already, so I know that it's likely safe to come out. The other thing I like to do is I like to remove the trocar on lateral view. Go back to lateral. Actually, set up pretty quickly. Picture. All right, so picture. 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 All right, I want to make sure there's no tag of cement following the trocar. Picture. And there is not, okay. So I'm going to go ahead and pull that trocar all the way out, and then we're done.
Cool. Perfect. And one more. Okay, let's come back around to AP, John. I got it. Okay, so the final balloon kyphoplasty we're going to demonstrate is the Arcadia balloon by Merit. And tagline on this one is bilateral results with a unilateral access. And so again, we're going to use the single bevel needle. I'll start off with that. Don't need to demonstrate it again. We will do an adjacent segment right here. Okay, so that's a good start point. And we will access exactly the same as how we'd done previously. And, you know, I'm going to do a pretty flat approach on this one as well, rather than the 10 o'clock, 2 o'clock position. I'm going to do more of a 9 o'clock, maybe slightly higher than that. The shape of the Arcadia balloon, as you will see, is different. All right, so same thing, we don't violate the medial wall of the pedicle until we know we're in the posterior portion of the vertebral body. And hopefully we'll be a little bit short. I'm going to show you a redirection. We're past the posterior wall on that, so I'm going to go ahead and take it in a little bit. And then from here, we'll use the power curve. So I'm going to disconnect this. I'll take the power curve, which looks like this, as a directional capability. This turns clockwise. The directional capability is indicated by this arrow approximately, and the tip is beveled coincident with the direction of the curve. So this face of the bevel steers the needle away from the face and toward the point, and when you twist this, this turns, and so it extends to very nearly a 90-degree amount of curve. So I'm going to put this in. We know that this is going to steer along with the directional arrow. The proximal indicator is here. So we're going to steer this thing medially. So we'll take a look under fluoro. And as this comes out, I'm going to advance it a little bit into the trabecular bone. I'm going to keep it straight and advance it a little bit more until we're about approaching just past halfway from back to front, which is approaching that. And then once we're just past that, I'm going to start to curve. And you have the capability of controlling the tension on this. This is done by a single wire. And I'm going to start curving this over. And we're going to see that as we advance, the needle will start to look like it's coming end on toward us. And as we do this, it is coming end on toward us, and we'll come back toward the AP, and that's how we'll get a good medial lateral orientation, how we know we're far enough across. And so again, this is unilateral access with bilateral result because we can go all the way from one side to the other. So I'm going to go a little bit farther with that, knowing that we're about end on, and so that's perfect. So I'll untighten that, I'll remove it, and the next step is the balloon. Thank you, Grant. And the balloon has a regular inflator like a Levine syringe, but the knobology of the balloon is this one follows a power curve. It has the same tip. This turns right tightens, and this will turn the direction. So I'll demonstrate this. Turn the direction as it turns right. The balloon goes opposite of the inflation lure lock, and this will go this way. This will allow reintroduction. This is introduction into the needle, and once this is inflated, you can use it again, but it really helps to get back in the needle to use this. So I'll unscrew this, straighten the balloon out, use the inserter, cover the distal tip of the balloon, place this in, and I'm going to put a little curve on this as we go back lateral. Put a little curve on it so when it comes out of the distal tip, this will follow the original direction and pathway of the power curve. So we'll take a look lateral. We should see this and follow the direction of the power curve is that we put a little bit of pressure on that. Here it comes around the bend. You can see the markers. Okay, and let's take a look AP. Before we deploy, just make sure we're far enough across, and I'll deploy the balloon, inflate the balloon in the AP view. So that's pretty good. I'm going to back it up just a little bit. So the marker bands are right there in the midline, and then we'll inflate. This is a 15 millimeter balloon, and this also is pressure rated 700 PSI. I can tell you that this goes far higher than that. Both high pressure balloons that we've seen will go easily up to 1,000 PSI and beyond that. These are made out of nylon. They are monomer resistant, meaning the liquid monomer that's present in the bone cement formulation. And that is good. Let's have the cement now. I'm going to take this back down. And let's have the cement. I'm going to place this as stability cement. Typical insufflator. This is cement in this cartridge here. And this part hooks on to the initial needle so we can get a good, nice attachment. And this cement should be baked and ready to go. Compliments to the chef. And so let's go back lateral. So I'm going to go ahead and, for sake of brevity, I usually don't inject the cement until I can see it, but I'm going to start doing it now. So we can see our balloon burst a little bit there, and I will show you how to counteract that. In a person, the blood flow would take it away, but we can see that there will be a little bit different density in the cement that's being injected than is in the contrast density. So we're filling up with the cement now. We can see the contrast running out. Back in the olden days, we used to inject contrast in the vertebral body so we can see routes of egress to, better control our cement injection. But we don't do that anymore because it's just a waste of time. All right. All right. So maybe we need to get the cement that is not quite so done, or now it's coming. There it is. You can see the double density is starting to fill that cavity. As you can see the rest of the contrast coming out. Difference between cement and contrast is this cement very likely has quite a bit of viscosity with it. I mentioned the 800 Pascal seconds of viscosity of the previous cement, Stryker cement HV that we used with the spine jack. This is probably about the same. It's hard to turn. My pressure is up between 300 and 400 PSI. And so this is, in terms of Pascal seconds, the viscosity is very thick. And you can start to see the contrast dissipating and the cement taking its place. And we're going to keep coming up, keep injecting cement. Inject as much cement as this will allow us to. Okay. Boom. So that's as a torque limiter right there. Will only allow us to inject up to a certain pressure. And then the clutch gives way. It's still going though. And we like the flow, the pattern. So cement kind of follows the pattern of everything else in life. More is better, except for taxes. So we're going to keep going. I like to get a little bit more in there. Still filling. Working time on this is excellent. So the final goal is really, ideally, we want to get end plate to end plate between the pedicles. So for your cement deposition goals, that's kind of ideally what you're looking for. We've got quite a bit of cement in there already. I think based on my my clutch limiting, I'll probably have to stop injecting right there. That looks pretty darn good. Pretty darn good. Okay, let's take an AP shot. So very nice fill. Smack between the pedicles, end plate to almost the bottom end plate. And we like it. That will provide a very good stable fix over time. So I'm just going to disconnect here. I'll put the stylet back in as was demonstrated previously, make sure the cement doesn't come out. Pull it out, and that is the Arcadia balloon by Merit. I think we can open up for some final questions and comments.